here, Deanna being one of them. And we have Anna Treadaway and Christina Bird Calato. And so again, want to just say I'm a member of the Shriver Center faculty and on the LEND program, and very proud of the work that our fellows do. And so I'm happy to be here. So, okay, so let me get us started. Hang on for just a moment. I'll get my slides. Oh, let's see. Here we go. All righty. So here we are, ready to talk about health transition for youth and young adults with special health needs. And of course, we're the Department of Public Health and the Division of Children and Youth with Special Health Needs. So just to put together some learning objectives for tonight, really my hope would be that by the time we're done, that you would feel comfortable and able to explain the importance of supporting youth and young adults with special health needs and their families in their transition to adult healthcare. And that you would know where to find and how to use the GOT Transition National Resource Center's 6 core elements of healthcare transition, and also some other health transition related tools and resources. And then certainly recognizing among these that I'll be sharing in a moment, some best practices. So what is Title V? That's where we're from. The Center, or the Division for Children and Youth with Special Health Needs, is one part of Massachusetts Title V program. And every state pretty much has a Title V program as part of the maternal and child health, funded by HRSA and the Maternal and Child Health Bureau. And we are, the Maternal and Child Health Bureau is one of the nation's oldest federal state partnerships, as you can see here, started in 1935 under the Social Security Act, specifically for maternal and child health. And so what the programs across the country aim to do is improve health and well-being. And listed here, you'll see mothers, infants, children, and youth, including children with special health care needs. But in addition, we're looking at fathers, extended family, siblings. That's all part of the big picture. So that's what you see here. And then one of our ways of delivering our services is that every 5 years we put in an application for a block grant. And what we do to prepare for that is usually about 1.5 years worth of a needs assessment that we do by conducting key informant interviews, focus groups, and other ways to find out what the emerging issues are that are coming up within the field for children, youth, and families. And so to that end, and then what we do is apply annually to continue our funding, and we report on our results. And all of that is available in the public domain. If you go to the Maternal and Child Health Bureau website, under Title V, you should see every state's Title V application and the report of the activities and the results. So talking about who we serve, children and youth with special health care needs, Maternal and Child Health Bureau back in the late 90s, but actually as early as in the late 80s, started to define children and youth with special health care needs very broad and inclusively. So as you see here, it's anyone that up through, I would say, age 22 in our case, but according to the National Survey of Children's Health, it's through age 17 right up to age 18. That said, it's those who have and who are at increased risk for a chronic physical, developmental, behavioral, or emotional concern, and who also require health and related services of an amount of beyond that, which is required by children generally. And we estimate in Massachusetts that's about 21% of children between the ages, again, of birth, and actually it's through 17. So we talk about health and transition a lot. We talk about transition in a whole variety of different ways. One's transition moving from secondary to post-secondary education, or to further training, to employment, or some sort of vocational work and activities. Things like having independent living skills, being self-determined, and one's ability to also determine what a good quality of life is and what you seek for that purpose. But one area that we don't talk about a lot, and we should talk about a whole lot more, is healthcare. And so that's where I'm coming from tonight, and happy to speak to that. So at the Department of Public Health, and actually in maternal and child health in general, what we mean by healthcare transition is simply moving from pediatric to adult healthcare systems. But also what's really important is for youth and young adults to be ready to learn about their own self-care and self-management as far as is developmentally possible and appropriate. But that is a major goal of transition, and certainly a major goal within public health to provide ways and avenues for youth and young adults to do that work and learn about their needs, and working with pediatricians and also with all of their providers. So how many are we talking about here? I just referred a few moments ago to the National Survey of Children's Health, and for us, that's really a central data tool for us to understand on an ongoing basis annually as the survey changes and updates itself. What are we talking about in Massachusetts? So right now, the estimate for the total number of youth of transition age, and we're going to call that between, according to this survey, 12 to 17, is 486,000 youth. The national survey does not go above does not start at 18 and above. So we're capped off through the 17th year. And so if you think about that for transition, that actually leaves a lot more questions than answers, actually. But just know that when you're looking at the National Survey's data, that's what you're looking at. And so in thinking about special health needs, then we're looking at 128,000, we'll say roughly, between 12 and 17 that fall into that category. And of that group, those who are most medically complex are somewhere around 1 to 3%. And so we're just, conservatively estimating somewhere between 1,300 to about 4,000 in the state. 2/3 of youth with special health needs, and as reported by their families in the national survey, say that they are not receiving services for a successful transition to adult health care. So that's an important number to keep an eye on. And I'm going to share a couple more bits of data with you in a few minutes that will help make the picture come clearer. So as I said earlier, if you're thinking about the fact that this only goes through age 17, with many more, and I would say conservatively, again, from 18 to 26, and we've even heard, we should even be thinking about transition from some of our key informants straight through to age 30. So that doesn't seem completely out of the range, quite honestly. But again, this is a group that we need to know a whole lot more about, and we need to be thinking about as they move into all of their adult years. So why is it important? Youth, all youth, if you think about it, must transition from pediatric to adult-centered medical care. And this process, if you think about it, someone having a special health need, is complex. And then if you layer on social determinants of health on top of that, it becomes even more complex. So it's a process that really is individualized and specialized, but it's definitely requires a lot of forethought, planning, and then follow through on the other side of transition. But so there are barriers then, therefore, that can affect and prevent effective transition. But the good news is that there have been protocols developed to improve this process, and that it is influenced by much as we're doing right now, provider education. And there are still, of course, gaps in medical education. So again, more time and attention needs to be spent on this topic, so critically important. And the one thing that we know underlies it is potentially no consistent measures of what constitutes success in transition. So several years ago, myself and a group of colleagues at the Shriver Center did a needs assessment, actually, in Massachusetts. And this is dated 2016, so it's a little dated now, but I would still say that the findings are, I think, what we're experiencing at DPH as well. And so what we're hearing is that parents and the child are attached to their pediatrician, and therefore there's a hesitancy to transition to adult health care after having all of those years with a trusted provider. And yet, as well, there's a lack of adult health care providers with experience or training in this topic, and also thinking about disability and chronic illness as well. There's a lack of sufficient mechanisms to adequately bill for these longer medical appointments that are often needed by people with disabilities, and particularly when you're having these kind of specialized discussions, such as transition. And then the lack of adult providers, of course, as well. And we're seeing this right now in COVID. We need more adult providers trained in mental health. And some with disabilities and special health needs may continue to see pediatric providers well into adulthood. And I've heard in many cases as old, I've heard as age 50 in some places. That seems like a lot, but that's not unheard of. And my guess is that many of you know this. So how many, back to that number I shared earlier, report being served, receiving services necessary for healthcare transition? So you can see here in Massachusetts, it's 37%, and in the country, it's at about 23%. And so, but the good news is, if you take a look, in 2016, the National Survey of Children's Health started a new version where it, instead of surveying every 5 years, they surveyed every year, and then every other year they update for states as well. So they combine this data. It's a smaller data set than what they had in the past, but it is a more frequent data set. And as you can see, starting in 2016, that this report came in at 16.5%, which was very low. The next year, it jumped up a little bit to 17.9% reporting that their youth had received services for transition. And then the report that combined 2017 and 2018 then came up to 30.6%. And we weren't sure if this was an anomaly or not. But in the last report, you can see that it then came up further to 37%. And so I guess I would suggest that that's a systems level type of improvement. And I would say that it takes, the whole takes a village to get behind, someone with a disability or a family. I think that that's the effect of the village. And I can only hope that it will continue to go higher as we all continue to become better educated, start to work together collegially and collaboratively to move the needle forward on this. So then the question is, okay, so how many have spent time alone with the healthcare provider? And this looks a little bit better. This is 65% roughly in Massachusetts compared to 41% nationally. And this actually rose from last year's report at 60%. So we're doing a little bit better. Again, very hopeful as we start to nudge things up the scale. And then how many worked with youth to manage health or healthcare or to understand healthcare changes at the age of 18? Again, a very, very positive number of almost 76%, and fairly, alongside the rest of the country as well. Last year it was reported at 80%, and so it's gone down a hair. But again, we have to watch to see how the numbers stabilize over time. But this is typically reported, pretty well. So then the question comes up about how many providers discuss that shift to adult care providers. And here you see 26.3% for Massachusetts and 22% for the country. And there really was no change from the last report. So this is one I think we have to pay attention to and think about how can we encourage that discussion of that shift to adult care providers. And that's something that I think it's worth discussing. So then what are we doing at our Department of Public Health's Title V program? What's our state action plan for health transition and we've created this new acronym that we're calling Youth and Young Adults with Special Health Needs. So that's something you probably haven't seen before, but it's something we're embracing because in interviews that we've done with youth and focus groups with youth and young adults, from 18 to 22, they don't want to be called youth anymore. They really see themselves as young adults. And so to honor that, we have changed our terminology. So this is our division and the work that we do. And it's a house, and the roof of the house is our aspiration, our vision for Massachusetts to have optimal health and quality of life for children and youth with special health needs and their families. And our mission is by assuming a leadership role toward a comprehensive service system and working in partnership with families and youth and other stakeholders, and assessing needs, strengthening our infrastructure, ensuring access, enhancing expertise and knowledge, much as we're doing now, and always really engaging in quality improvement on a continuous basis. The house is based on these 6 core pillars that you see here, which are part of Healthy People 2030, the 6 core elements for children and youth with special health needs. And one of those in green you see is health transition. So I'm going to focus on that. And all of the work that we do is on this foundation of our values. And so to that end, one of our key values is partnering with youth with special health needs to improve health transition and promote self-advocacy and self-care and self-management and all of those things. So I'll just call out those pieces in the house today. So our block grant goals by 2025 were, and I think we looked, as I mentioned earlier, we looked at that number of 30% in the last report as what we thought was an anomaly, moving from 15.4% back earlier than 2016. And then we were conservative and said, well, maybe in the next 5 years we can move up to 20.6%. But in fact, last year it was 37%, as you saw. So it'll be interesting to see, how these numbers are adjusted. And to be 100% informative on this, the 20.6% is something that maternal and child health sets as our target, not Massachusetts. And I think I would probably want to see that go up a little bit higher. So then what are we going to do about it? So we have 4 strategies that as you see here, and there's a whole drill down of activities under all of these. But basically, we have a number of services that I'll share in a moment within our division that help to increase access to transition resources and information through our community support line, through our care coordination program, through our pediatric palliative care network, and other services that we provide. And in doing so, we provide racially equitable, culturally and linguistically appropriate services. And we do this based on individual needs, moving through the transition process. So many of our staff are bicultural and bilingual, and we have a language support line that helps us for families that don't speak the same languages that our staff speaks. But we are always moving in this direction in our hiring process and just in how we do our work. Another strategy is to engage youth and young adults with special health needs to ensure youth voice, and for us to be listening to youth voice in how we strengthen the system and align services for health transition. And then some ways that we're also trying to do this is by a lot of internal and external outreach and collaboration with our colleagues. And so internally within DPH, we have other programs such as adolescent health or substance use, or let's see here, nutrition and mental health and things like that within DPH. And then we also have partners such as you, clinicians, and also non-medical providers, and our sister agencies, such as I saw Margaret Van Gelder here earlier, so the Department of Developmental Services and the Department of Elementary and Secondary Education and others, to strengthen this system and align these services around health transition in our case, but transition in general with our sister agencies. So some tools and best practices that can help us manage the transition. So right now, this summer actually, we've been building toward this over the past year by having intern support in doing focus groups and key informant interviews to figure out how to put together a health transition toolkit with youth voice. So how do we best recruit youth and young adults with special health needs to have some hand in this and to help us think about this and what they need? How do we listen to families as well? What media are they using? What ways do they want to meet with us, maybe that are not traditional? So we've been doing a bit of that work, but we're getting ready this summer to have 2 more interns through University of North Carolina's Workforce Development Center for Maternal and Child Health are going to help us put together a transition toolkit. And it will include a hybrid of the GOT transition elements, as I mentioned earlier, something called Charting the Life course, which is a tool that's really a very person-centered planning tool that is got all sorts of great graphics and supports to step a youth and a family through this process. GOT transition is really focused, I think, on providers as its first goal, but then in recent years, they've started to really put in assessment tools, self-assessment tools, readiness assessment tools for youth and families. And I think they're continuing that process. But Charting the Life course really does complement it well. And then in addition to that, we have many of our own resources at the Department of Public Health that we've put together over many years, one of them being a bridge to adult health coverage and financial benefits that we have a Social Security information and public benefits specialist put together. And we also have a website that we have built up over a number of years that has information for youth and young adults, as well as family members and providers. And then as you can see here, we're looking at transition holistically. So we're looking at things like mental health, sexual and reproductive health, relationships and healthy relationships, healthy nutrition, physical activity. We're hoping substance abuse. We're hoping to put all of this into this toolkit so that it is well-rounded and inclusive. So, here are the GOT transition 6 elements of health transition, and I'll briefly say that it starts with having a transition policy, and then it goes from really having a procedure where you're tracking and monitoring from the age of 12 and up the progress that youth are making in that transition process. And as I mentioned earlier, having some sort of a readiness assessment, and then the planning begins in a collaborative, continuous process. The most important piece is that transfer of care, and that's the part that I think is often the hardest part. So again, by creating a checklist, preparing the transfer package, and then communicating with a new provider, and then looping back in the completion where the adult provider then loops back with the pediatrician or the family practitioner or whomever has been the main medical home for that youth or young adult to complete the transfer and report back on how it's going. And by the way, I will share links to this information at the end of this presentation. So then there's Charting the Life course, and they have a whole section in this life course tool. Again, I'll share the link at the end. They have all sorts of videos and so forth, but health transition is in there. And so that's another piece I think that's worth looking at. And there are even questions that you can ask yourself about your readiness in the process that they provide. But it also wraps around all sorts of other pieces of one's life domain, and pulling out health transition as part of that. Then there's also the Massachusetts Family Engagement Framework, which is a very exciting new tool that's been put together in collaboration with the Department of Elementary and Secondary Ed, the Department of Early Education and Care, and the Department of Public Health came together at the beginning of this process over 3 years ago, and then started to do a lot of outreach to stakeholders to get their input into what engagement looks like in Massachusetts across from prenatal all the way up through young adulthood. But what's in here is also transition. And so it's looking at things like transition within education, but also transition within health. And because public health wanted to make sure that that got into the framework, we had a voice at the table. There are now 11 state agencies that have signed on to this. All of their commissioners have supported this document. So I'll have a link at the end, and I would highly encourage you to take a look at it. So then how can our programs at DPH assist? So these are all of the various programs that are within my division. As I mentioned earlier, we have a community support line, which is really the portal into the services that we provide. We will speak with anyone, and our specialists will help families navigate the system of care to find what they need based on a presenting problem. They'll also do a full intake beyond the presenting problem to see if there are other things that we can help them find to really strengthen the family system and give them the supports that they need. We have, for eligible families, care coordinators who are dedicated, bilingual, bicultural, located in the various regions across Massachusetts. We have a catastrophic illness and children relief fund, which is the payer of last resort for durable medical equipment and other things that Mass Health may not cover. We have family initiatives that provide leadership training for families. Family Ties of Massachusetts is a family-to-family support network that with lived experience that help families also navigate the system. We have a hearing aid program that for families who are not able to get hearing aids through Mass Health, and often these are immigrant families that we will pay for the hearing aid for their child with special health need. Our Pediatric Palliative Care Network for children with life-limiting conditions. It's a family-centered program, so lots of services that wrap around the families. Mass Care is an HIV/AIDS program with peer mentoring. Mass Start is assistive technology and support to nurses for children on IEPs in the classroom. So Children's Hospital and UMass Medical School are the two providers at present that teach nurses how to support a child in the classroom with assistive technology. We have the medical review team. Deanna, I see you raised your hand.
No, sorry. It was,
okay. I'm sorry.
Go for it.
Yeah. If you need to give me a time warning too, please let me know. So anyhow, and then our medical review team is for respite care for those families who have very medically complex children, and it's for short-term care in a pediatric skilled nursing facility with approval, and it's meant to guard against institutionalization. So it's a pretty stringent process. And then there's public benefits training that we provide, and our universal newborn hearing screening program to follow up on birth records that show that a child may not have passed a hearing test. Here are some information regarding phone numbers that you can call to receive some of these services, to get a copy of the brochure that I showed earlier, and to take a look at our website. And then we also have, a number of ways that we help with the transition process through our care coordination program. Every family, I think it's about 157 families altogether, who have transition age youth that are then stepped through the process from age 14 all the way and past age 22 in those cases. And then, of course, Family Ties works with the families that they serve in that respect. Public benefits training, we'll talk about what happens at the age of transition. Our website as well has that information. Again, working, sharing awareness and information across health transition with the various agencies that I mentioned. And also we participate on Boston Children's Hospital and Brigham and Women's Weitzman Center has a neurodevelopmental disabilities transition initiative. And they have invited really anyone, any medical providers in Massachusetts to get on board and join this transition initiative, where they're doing tests of change to see what we can do to improve that process. So here are the resources and the links that I mentioned earlier. I won't go over them, but I'll just say that they're here for you if you need them. And that is all I have to say, but I'm happy to take any questions if we have time, and I'll stop sharing my screen.
Well, thank you very much. I think especially the more recent statistics was very interesting to see. I'm so happy to see that there's so much improvement. So we do have a question from Carla Distrap, who is the Associate Director of Performance Improvement at Highland Healthcare Associates. And so the question in the chat is there any work being done to assist adult providers to become more capable of providing care to special health needs youth who have transitioned to adult providers?
Yeah, that's a great question. And then really, I have to say that, lots of work is being done on the pediatric side, but there is no transition without adult providers. And so the work is being done there. And I think that's where that neurodevelopmental disabilities transition initiative is key, because adult providers are being invited to be part of that initiative. And in those conversations they had, and I was on the planning committee for a summit meeting that they had back last November. And that got, I think, some of the gears turning and people interested. And, there are conferences, that I've been invited to as well to talk on this subject. But I do think that for us at DPH, in the next 5 years, that's a goal for us as well, to really to get out there and to start talking with adult providers and seeing what we can do to expand capacity.
Great, thank you. And if anyone has questions, they can feel free to unmute themselves to ask. And I actually do have a question if no one else has one right now. So one thing that was very interesting to me was how the education of the provider and provider bring up the transition really does is thought to improve this healthcare transition. And so what was also interesting is that when I look at board specifications, there's often very limited specific, I guess, specifications on what needs to be known about transition. And while I completely understand that there's a certain element that is based on the local resources, I think there's also some common elements too. And that's why we have these national websites. And so I guess my question is are there efforts to work with the specific specialty boards to sort of develop specifications for what we want trainees to know about transition?
That's a great question. And I would say not at present, but it's a great idea. And, I think this is where, over the next 5 years, we've got our tentacles going in every direction. We're looking at youth, we're looking at families, we're looking at providers, but I think the adult provider world is a place where we've got our work cut out for us. And I think in terms of speaking, getting the right audiences at the table and those that can influence education is something that we need to put on our to-do list. So, and partnering with all of you as well. I think that, we can't do it alone. And we really do need those doors open for us because we're not in the medical world directly. We're kind of monitoring it, looking at it, measuring it, and trying to raise awareness. But I think any doors that can be open for us, we would be happy to walk through.
Elaine, Karen Miller. I think the place that we need to be targeting, and I don't know of initiatives around this specifically, is medical school. I think that that by the time they get into residency, they're so busy trying to get things done and, I don't know, not kill anybody, that they would they're not as available, let's say, to changes in attitude, which I think is really the leader. Without the attitude, they're not going to seek the knowledge.
Yeah.
And I don't know what the process is in medical school to introduce people to care of younger people with disabilities. They get exposure to older people with disabilities, but not necessarily younger people with disabilities who want to actively participate in their care and have been used to doing so from hopefully early childhood.
Yeah.
So that would be an area I'd be interested to know if there's any initiatives or could be.
Yeah, right. I mean, and I think that's exactly right. I mean, I think one of the things that we know from our work in the LEND program and from other places is that, you have a captive audience at a certain point in time, and that's where those that are being trained now will influence the future. And it gets harder when you're out in the field and you're juggling so many different things. So I do think that your point is an excellent one. And I think, again, it really shows one goal for us, just to start making those inroads, having those conversations, and really trying to get a roadmap to how to make that happen. And so, and I guess I would say to you as well that it is happening in some places here and there. Like I can think about a colleague of mine who a few years ago had gotten a grant about transition for youth on the spectrum, and it approached the Graduate School of Nursing, of all things, out at UMass Medical School, and got into their curriculum. And after the project ended, it stayed. So there are different ways we can think about these things, and I just think it's part of it is to kind of come together, have creative conversations, and then see what the possibilities are. But I think you've named a few, and I appreciate that.
I would also put in a plug for physician assistants. And Tufts has an active physician assistant program, and we've been fortunate to add one to our Center for Children with Special Needs. And there have been other ones who've been interested because we went over and talked to them, but we didn't talk about the experience of disability. And I think they would be a great audience to talk about communication and what the idea behind self-advocacy really is. And they would be well placed to build it into the practice as a representative.
Great. I'd love to have a conversation anytime to sit at a table together and have, kind of explore a few things that way. So always open. Thank you.
Great. These are really great questions. Unfortunately, I do have to cut short and move on to our next awesome speaker. There's also a request to send a copy of your slides with the links. Is that a possibility? You can send it to me, and I could send it to anyone that's interested. If you're pre-registered, I will go ahead and send it all to you. If you cannot pre-register, please email me your email. Well, if you email me, I'll have your email, and I'll go ahead and send it to you.
Great, happy to do so. And I'm going to have to leave, folks. So I want to thank you for this opportunity, and I've enjoyed speaking with you and have learned a lot as well. I really appreciate it. So thank you all.
Thank you
Take
so
care.
much.
Bye-bye. Thank you.
Bye-bye.
Bye now.
Okay, great. And so thank you everyone for the great questions. So for our next speaker, we have Wesley White and Carrie White, who are here to give us a really great patient perspective on the transition care, and to really help us understand what is most important from a patient perspective that they wish providers do.
Hi everyone, my name is Wesley White. I am 29, going to be 30 this year. I currently work in IT, graduated college with a BS in IT, as well as went to vocational school, worked for Raytheon, all the fun, normal stuff I've done. And I've been told throughout my life that I wouldn't be able to do things, but I've been able to do every one of them. So, what?
And I'm Carrie White. I'm Wesley's mom. I have a master's in education, and I currently teach second grade. And we're here to tell you about things that have happened to us. We see ourselves sort of as pioneers, because a lot of the things that just were presented in that last, by the last speaker there, were not present when Wesley came up through the ranks, and we struggled a bit with it. So it's really nice to see that so many things are moving forward for a better life and for the transition years. It all actually boils down to the providers, and we'll touch again on that later.
So we are going to have a different layout compared to what Elaine did. Ours is going to be more of an open discussion, if you will. So like, if you guys have any questions over the stuff that we're going over, feel free to drop a question in the chat and we'll get back to you. But I figure it's good to start us off with some of the questions that some of you may have beforehand. So one of the questions I often get is essentially, was there any fear of growing up when it comes to like transitioning and stuff like that? So I think it's safe to say, as we all get older, change happens, and having autism change is hard for most of us. And I feared changes more than I did becoming adult, if that makes sense. So the other question that I often get is, was it easy to find a primary care physician for me? So I was in, I'd say, the 70% of what Elaine was talking about previously, where we didn't necessarily have that transition plan. And quite frankly, and I'm not saying because of the doctors, I'm saying it's just it wasn't around at that time period. And it was very difficult because when you are a adolescent or a kid, essentially, you have all these specialty doctors such as developmental pediatricians, child psychiatrists, uh, pediatric doctors, etc. But when you get to a certain age, both the insurance company and the doctors themselves tend to drop kids off because of their age and possibility of wrongful whatever being sued, essentially. So it took me, so currently right now there is no database full of doctors that have good reviews on people that have autism. It took me a couple doctors in order to find a doctor that fit me and my lifestyle, as well as understood me as a patient. Because as a patient, some doctors might assume that all cases of autism have the same quirks, if you will. However, no two cases of autism are ever exactly the same. So it was a fun experience, especially considering not all doctors are willing to prescribe medication that we might be on without seeing a psychiatrist, even though we've been on the same medication for many years prior. So
I'm just going to pop in there for a minute. So it's really about the partnership that people can offer, because partnerships work in a way that if you don't have the answers, you help someone find the answers. And that's really, I think that that's just a key point, because children and young adults that have autism know whether or not you're genuine and whether or not you're going to actually help them. And that's what it's all about. And so we were really actually very lucky. The developmental pediatrician, Dr. Miller, kept us on for a longer time, as well as Wesley's pediatrician, who kept us on through college. And so that helped us. But we really fell into a deep, dark hole. And that's sort of like the difference between elementary school and high school. And there's no middle ground. And so that's what we really are here to advocate for, is that place that needs that transition plan is a big place. And it will not only help children that have special needs, but it will help all children as they try to separate from what they've known to the unknown. Again, it's about relationships, I think, that you develop, and that you're willing to be a partner. I'll go back here to you.
You can go next.
I wanted to do this one.
Yep.
We realize that we can't lay blame on anyone, that things are evolving, and that we really are pioneers. We've made some missteps, and we've, pulled ourselves right back up and kept on going. And that has been what's saved us. So we think that when you think about resources that we wish there were, that's the area that really needs a lot of work to be done. And we saw evidence of that on some of the slides. So that's really good news for families. It was hard to find resources for us. You don't know where to look, it's overwhelming. You don't really know what you need. Some of the times you don't know what you need until you're there.
And technology was also different back then. So when I was growing up was like literally the beginning of the internet, whereas like today you can easily just go online, do a Google search, oh look, they're doing something on autism, and essentially find good resources there. What else we got?
Well, I don't think the families are hesitant to make the shift. I don't think that that's the case. We weren't hesitant. We just couldn't find what we were looking for. We couldn't find, there's primary care for adults is very different than what you get for children. And it's just, it's a really rocky road until you land there. And so we went without, which is never a good thing, even though we had insurance, just because there wasn't something that felt right to us.
For example, so Dr. Miller, I was lucky enough to have as my developmental pediatrician when I was younger. And whenever I'd go into a doctor's appointment, she'd always ask the necessary questions in order to help us get to the tough conversations, if you will, such as how's the medication working out, how's your weight doing, are there any difficulties you may be having at school, all that kind of stuff that most doctors would often just be able to get by asking, is there anything you want to talk about? So my first conversation with those first two doctors that didn't work out essentially went, okay, well, I see that you're here. Do you have anything you want to talk about? No, not really. So it was a simple in and out, and that kind of
that fell short. So the scripting is awfully helpful for people that need it, like having a routine or a script of things that you ask them, or sending some questions out front, perhaps. Now that might even be a way to, here's some things we're going to talk about. So again, those things that get you ready might have been helpful, but we didn't know. It was kind of trial by fire. So yeah, what else do you think we had here?
Let's see here.
Biases and misconceptions.
So we already went over, a lot of people think that there are biases and misconceptions that are had. Essentially, like I said earlier, don't make any biases, or don't have any preconceived biases where, like Down syndrome, where once you've seen one person with Down syndrome, you've seen them all because of the age gap and whatnot. Every kid with autism is different. They all have their strengths and weaknesses and stuff like that. And essentially, every relationship that you form with the patient, that person will remember essentially until the day they die, essentially. So it's one of those very strong relationships that you're going to end up making, and they know that as well.
I think that when children are younger, they're a little more available to, social groups and counseling and things like that. But when you get into the adolescence and you get into the young adult, but it's a lot harder to, as a parent, it's a lot harder to coach a child and have them seek that service out, where it would still be very helpful. It's really hard to make that happen. Whereas when they're younger, you can just pop them into groups and you can go and visit psychologists. But that is a piece that falls by the wayside, which is sort of a lost opportunity to continue talking with others and realizing that you're not alone.
Mm-hmm. What questions do we have so far?
All right.
What are the most helpful services providers in negotiating transition to adulthood? Great question, Jay. So realistically, we didn't have any at that point, just because it was such a new field. So like when I started doing the transition, I'd say I was probably
high school.
Older than that.
Were you older than
Yeah,
high school?
I was in college, essentially, because I was lucky enough to have Dr. Miller and my own pediatric doctor, Dr. Moffat, who understood me as an individual and who knew that too many changes at once might overwhelm me, as well as what I was capable of handling at the time, because college is a massive change in life. And quite frankly, they were dead on. And once I was in the college swing of life, essentially, they were able to say, well, I think you're ready to spread your wings and learn how to fly now, if you will. But it's definitely a transition nonetheless, and transitions are hard on kids who absolutely hate change. So-
There's the rub. There's the rub. Hi, Dr. Miller.
Hi, I'm thinking if I was an adult doctor, and I'm used to my own scripts, such as what do you need to talk about today? And they need maybe a different script. And they say, what would be, I'm trying to think of what I would train an adult doctor to say differently. They may, I would imagine, know that you have a difference from whatever little checklist they completed.
So
And
maybe
yet they don't want to be, assuming that you fit a stereotype of an individual with autism. I'm just trying to think of what I want.
So fantastic question. Fantastic question, Dr. Miller. To me, it's a lot of it's about the relationship you build with the patient, if you will. So once, or the
the
provider.
provider, yeah.
Once you have that relationship, then they'll open up to you like a flower, essentially. And what I mean by that is the questions honestly depend on how often you've seen that individual. So you might have to ask the tough questions to begin with, but once they get to open up to you, such as, do you have any medications you might need filled? Do you have any accommodation requests that need to whatever? How are you feeling today? Has anything been bothering you? Something like that.
Well, I think in that conversation that you were so good at, like, tell me about your medicines. So instead of it being a question,
Yeah.
phrasing it in a different way. So tell me about your medicines, and have you had any problems with your stomach? I noticed that, last time we talked, you weren't eating any vegetables, Wesley, so kind of things like, right, things like that, or more taking the questions that a doctor might say. So instead of like, how are you feeling today? Because that's too big. Like, what are you talking about? Work? Or are you talking about what? Like, channel it right in and say, have you got your vaccine? Really be direct and then back off, because they'll know where to go. It has to be pretty directed, pretty scripted, I think, to have success.
That's exactly what I was struggling with, because if you start with an open-ended question, there's this dead silence afterwards, and yet we're trained to ask open-ended questions rather than directive questions. And I'm wondering, from preparing it's one of the things that I would imagine would be a struggle for somebody who has little experience working with individuals on the spectrum, to know that there's a balance between an open-ended question and not putting words in their mouth,
right,
and being almost respectful, and it varies so much with the individual.
Yeah, it's like it's black and white and shades of gray, right? So if you think about that, so things are pretty black and white, and there aren't a lot of shades of gray. And so if you are just a little more direct, it seems to work better. It's not taken as being bossy, it's taken as caring about you. So you really cared about me because you asked me that question. And one of the things that will often go with autism is this great disorganization, right? So if you ask me how I'm feeling today, I don't know where to start with that. I don't know whether you're talking about, how my stomach's feeling, how my ride in was, what kind of a day I had, right? And so if you just narrow that, cut to the chase, I can really understand what you're asking me.
So I'm wondering what the role of the individual is in educating the providers. So if we're going to be the pediatric providers preparing the individuals, it's like having an introductory speech if you're a politician. You know, this is who I am, this is what I need. And maybe what we need to think about is preparing your introductory speech for an audience that doesn't need to know you have autism and an audience that does need to know. And having practiced that, to tell the other person how you want things talked about.
Right.
And maybe that's what we need to have a checklist for.
I think another thing that has to truly be thought about is, I don't want to say it's a generation thing, but it really is. And what I mean by that is a lot of the newer generation, when it comes to people coming up in residencies, people going through college right now, that one of their requirements, I know at least in UMass Lowell, is they have to do a paper on a specific person that has an intellectual disability or something of the such. And that then, some people see it as essentially busy work. Other people actually truly learn and grow from that whole entire experience. But the trouble is, when it comes to doctors, a lot like teaching, that's not necessarily a required course, if you will.
And then the other thing we really need to let you know is that advocacy that we're expecting young adults and teenagers to be able to do is very difficult. There is the biggest hurdle. As a parent, you watch it, you try to teach it, you have all kinds of scripts and things, but it is a skill that's very hard to teach Wesley to advocate for himself, because he's not going to do it. They'll shut down and just be quiet. And so it's like the round block in a square hole. It sounds wonderful on paper to get children to advocate for themselves. It is really difficult to do. And so I think that that's probably not a doctor's job, but just realizing that for some people, it's really hard to advocate for yourself. It's really hard to know the questions you're supposed to ask. It's really hard to tell them that you don't understand what they're saying because they're going to judge you, right? So we don't understand what's going on inside other people's head, but that advocacy piece that we think children are going to be able to do is just very difficult. So I think our plug is that children, adolescents, youth fall into this depressing hole that they can't get out of very easily, and it is depressing for them. They don't have the skills to advocate for themselves. Their parents are not allowed in to advocate for them, and so you have this real mismatch. So if I could redesign it, I would have another specialty area that is a link between a pediatrician and adult care, young adult care, something else in there that might maybe help with some of the problems that we've been through. And hopefully other people won't have those problems.
Or just have some type of network where you can go and say, okay, this person's certified in such and such, right? Because right now you can find doctors that specialize on eye care. You can find doctors that specialize on foot care, ear, nose, and throat, all that kind of stuff. But right now, when it comes to a primary care physician or an internal medicine doctor, there is no certification for either autism or anything with special needs. They'll essentially point the finger and say, go see that guy over there. He's a psychiatrist.
Mm-hmm.
So
Well, I think we have time for one other question. I think there's a question in chat. If there's any other questions too, please email to me. I will definitely forward it to Carrie and Wesley. So the question in the chat is, what would you most like adult providers to know besides that one child with autism is one child?
Is it the resident?
it's got to be the relationship thing. So you got to build a relationship in order for there to be trust there. Otherwise, you're going to be shut out. So, like, for example, my current doctor, my current internal medicine doctor is my primary doctor. She and I have some of like the most random conversations, like, for example, dating or Mickey Mouse or whatever. It's the simple conversations that will help break the tide, if you will, when it comes to making that relationship.
Okay, great. We can squeeze in one more. So another one that just came up is, what about adolescent medicine at the medical home for young adults with disabilities?
What do you mean by medical home?
What's that? Is that John?
John, can you pipe in?
Primary care and navigation as an, I mean, adolescent medicine will say that they take care of kids from 12 to 25. And they do primary care, and they often will have social services and are comfortable with advising people about such things as guardianship and financial resources, and could be connected to disability services, Department of Public Health and the Department of Mental Health. And it would seem to me that that would be the group that fits in this bridge, as long as they're connected to internal medicine at 24, 25, 26 to get that transition taking place.
So I think, John, one of the issues that comes about is it's probably different now than it was when we came through. But when we came through, we were just blindly floundering along, finding our own way. We didn't have any. Yeah, we didn't have any resources or any state aid or anything like that. And I think that there's this big population of people that that maybe don't disclose that their children have needs like this. And so I'm just wondering in general about that group of children. So we're not really familiar with what you know. I'm glad there's something there.
Well, thank you.
Thank you. Well, thank you so much, Carrie and Wesley. This is really illuminating. So next we have Margaret Van Gelder, who is the statewide director of family support services at the Massachusetts Department of Developmental Services. And then I will go ahead and share her PowerPoint.
Great. Well, thank you, Deanna, and thank you for the invitation. I'm happy to be here with everyone and really appreciate Wesley and Carrie, some of your insights, and in particular, your focus on the importance of relationship building, because I think that theme will come through. Deanna asked me to talk a little bit about the family support services that our Department of Developmental Services offer. And so it's not going to be as much healthcare focused, but hopefully certainly some linkages to think about ways both individuals and families may get some support from some of our different programs and services that might help them navigate both the transition into adulthood as well as really across the lifespan. So I'll be describing some of our supports for families, particularly focused in their caregiving role. The majority of people we do support are caring for either a child or adult family member or supporting them at home. And so we have some specific services really intended to assist them in that role. So Deanna, you can go on to the next slide. So hopefully don't mind all my cues here. So the Department of Developmental Services is one of the state health and human service agencies, and we provide services and supports to children with developmental and intellectual disabilities, Typically, those children's services go up to what we consider age 22. We serve adults with developmental and intellectual disabilities. And then about 5 or 6 years ago, our eligibility was expanded to include adults with autism spectrum disorder who don't have an intellectual disability, don't meet that criteria, as well as individuals with Prader-Willi and Smith-Magenis syndrome. And so our eligibility criteria for children is different than for our adult services. And typically, we encourage individuals to apply for adult services at around age 18. It can happen later, but that's really when we have staff who can really start working on some of that transition planning as well. And so if any of you are working with families in a healthcare role, certainly encourage, if you think their child adult will be eligible for services, to think about a referral to DDS, because then we can really help explore other options. Currently, we serve approximately 43,000 children and adults in Massachusetts. Our services are organized into 4 regions, and we have 23 local area offices. So that's really where services are planned and delivered. We have staff that we refer to as service coordinators, and they would be the primary people having relationships with individuals and working with the person and their family. And we have staff specifically identified in that transition age called transition service coordinators, who work with the young adult and their family as they're starting to plan for that transition from school into their post-secondary options or into adult life. And so that's where the adult eligibility at age 18 or thereabouts is important, because that's when that opportunity occurs for that transition service coordinator to get more involved and really help facilitate some of that planning. Next. So I just wanted to share a little bit of background around just our goal of family support. So the next few slides are going to be sort of bigger picture, and then I'll get into some of the specific services and resources we have available. And really, we have a clearly articulated goal and principles around our family support services, and really want to be able to offer a wide array of options to both people with disabilities and their families that enable them to stay together and be welcomed, contributing members in their home communities. So it's really about often helping families develop their own natural capacity, understanding the nature of a disability, some of the skills, what information, resources they need, offering specific resources and goods and services, and in some cases, financial assistance. As we know, there's often extraordinary other demands placed on parents, caring for a child with an intellectual developmental disability, special health care needs. And so being able to sort of provide some additional supports or meet some of the gaps that might exist. And we also really see ourselves as trying to be those bridge builders to the community, to other resources and organizations and whatever, to really create meaningful ways for people to be engaged in all aspects of community life, which is really our mission, is to support people to be productive, contributing members of their community. We also offer a lot of more services focused on the individual. And you can go to the next slide, Deanna, that outline some of our principles of family support. And I think what's a little bit more unique about our family support services is that it really does focus on the whole family. And so some of the ways we can be helpful are really to look at siblings, or to look at resources or funding we can make available that will be helpful to everyone. And so different than some of our other services that are much more focused on helping the individual, whether that's, a supported employment service as an adult, or a coaching service for someone who might be going to college. This is really thinking about the person in the context of their family and what's going to be helpful in keeping that family strong. And we feel like that creates better outcomes, and everyone does better. And so we also, really want to be more proactive. We want to build on natural and community supports. As Elaine was referencing earlier, we're really committed to, but this is a continued, work in progress for us, is how we really do meaningful outreach and provide culturally responsive services, and how we have the capacity to really meet the linguistic and different cultural needs of all the different people throughout the Commonwealth. You can go on to the next slide. So, thinking a little bit about what we've learned over the years and what's really kind of the foundation or framework, there's been some national work that brought together professionals and family members really to do some thinking about what's really most important to families who are in this, lifelong role of caregiving and providing support. And so there was a report developed called the Wingspan Report a number of years ago, but they sort of framed this in terms of these key goal areas and then these, what they refer to as these buckets of services that I think relate well to some of the specific services we offer. So from the person's perspective, it's really how do we help the individual become self-determined, become more independent, recognizing that we're all interdependent. And so there's ways we all need support. How do people become contributing productive members in their communities, become employed, and have, be included in all facets of community life. And for families, how are they supported in ways that maximize their capacity, strengths, and unique abilities to best nurture, love, and support their son or daughter to achieve these goals? And always recognizing that interplay that individuals exist within a family system. So any support services, it's always that interplay. And so they've sort of defined the three buckets into what they call sort of discovery and navigation. People are often looking for the knowledge and skills, the information they need to sort of navigate resources, or who do I go to? Who's a good doctor, or who's a good therapist, or, if I need a speech therapist who's good with these kinds of things, or how do I apply for mass health or navigate insurance? And we often hear from families, sometimes you don't know what you don't know, right? So it's helpful to have people who have expertise in this area. I think the other is the power of relationships between families. And, we often hear that people often learn some of the best ideas, tips, resources from other families they know who are in similar paths, right? Walking in their shoes and have similar life experiences. So, it's really how do we facilitate those opportunities for connecting and networking and provide support to people in their parenting journey. And as we know, that sort of changes from when you have a young kid to adolescence, young adulthood, and then as individuals get older and age. And then the third bucket is what are those instrumental supports and services that both can help the caregiver. We all need a break. And in particular, when we're supporting families who have a child or adult who requires 24/7 care, we need some ways to really offer that break so people can get rejuvenated or take care of themselves, as well as other services that are beneficial to the individual, whether that's social or recreational or other skill development services. So on the next slide, you can go to Deanna, sort of provides a little bit of a crosswalk of how we think about these three buckets of areas of support and need, and how we try to address some of that through some of the different family support programs and services that we offer that include this array that I'll describe in the array of different services we offer, but information and referral, that navigating of services. And that's where that relationship really comes in, building a relationship with parents, the family, the individual, to really understand their family situation and what might be most helpful, providing training on different kinds of topics that are important to people. A lot around transition planning. That's a big focus in a lot of our programs, building those community connections and resources, and then support groups, social recreational activities, self-advocacy groups, skill development groups, as well as these instrumental kind of in-home skills building services, as well as something we call flexible funding, which I'll go into a little bit further. So on the next slide, it just sort of describes as we think across the lifespan, and I won't spend much time here, but when we work with much younger children, their primary services are often provided through early intervention, but our family support can be a complement and supplement to that. So they're working with families of young kids. We really encourage, as much as possible to make those referrals early on so we can get connected and we can offer whatever, additional services and supports we can. Likewise, when children are in school, the school program, the educational services are the primary source of support, but we continue to offer the full array of family support services, and the Family Support Center that we're going to be talking about is one of the primary contacts. And then in this 18 to 22, this transition planning age, this is where DDS gets much more involved in beginning to work with the young adult and family about, what's that vision for what you want to do post high school? Is it a job? Is it going to college? Is it some other kinds of experiences you need to figure out what it is you want to do? What other supports do you need at home? So they can begin to map out what adult services DDS can offer, what other community resources there are, and continue to be have accessible to them our family support services. And then for those eligible for our adult services, DDS plays a more primary role in that we offer a more comprehensive array of services, but family support continues to be a part of that because families can stay involved throughout the lifespan. Sometimes the person's living at home with them, other times they're supporting them in a more independent or in one of our group residences. So the next slide, and actually that's just sort of a good linkage, but you can just go on to the next one. Sort of the backbone of our family support services is our family support and cultural linguistic centers. So we have about 43 of these across our state. Each of our area offices has at least one of these centers available to them, and in some cases there's more than one. And one of the things I really want to stress is that if someone isn't eligible for DDS services yet, they can access services at any of our centers for some of these kinds of resources. So one is the information and referral. Just like the call community line that Elaine Gabovich talked about, people can call our centers to get some help with, information you might be looking for. I'm trying to apply for Mass Health, or I'm looking for a good a specialist in this area, or someone who can provide ABA, or I'm looking for some social opportunities. Can you help direct me? As I mentioned, there's a variety of trainings that all of our centers offer on a regular basis. A lot of them are virtual now. They, cover common topics, and transition from school to adult life is often an important one, but anyone can access that. As well as some of the family networking opportunities. There's a lot of different kinds of support groups or other ways families, they help facilitate some of those one-to-one connections. And again, around transition, that's an area where there's a real focus to bring families together who might be all have young adults at the same age who are all starting to plan, and might really bring people together to share information, ideas, resources, and to support them through that process. And what I really also want to stress is, because sometimes our eligibility process can feel sort of daunting, or people get overwhelmed with how many applications people need to fill out. Our support centers can help families with the eligibility process, filling out the application and walking them through that process. So, so those are resources available to everyone. Once someone's eligible for DDS, then there's other more specialized services, including this more, kind of intensive or comprehensive service navigation, which really is building that relationship with a family over time, but helping with a lot of problem solving, addressing, the coordination of other support needs, maybe helping with some educational advocacy. It can be a variety of different factors. It's really trying to sometimes pull all of those pieces together, or help people access and connect to other resources. This also can be really helpful sometimes for, we work with grandparents who are raising, grandchildren, or single parents, people who have a lot of other things on their plate, who need some extra assistance and support, that kind of case coordination role. We also really try to support and offer a variety of opportunities to bring peers together for social recreational purposes, or for learning new skills, whether it's cooking classes or doing yoga or self-care kinds of things, and also advocacy, building peer relationships, talking about relationships, those can really evolve and really be influenced by who's interested and what people are interested in. There's game nights and things like that. As I mentioned earlier, really building connections with different community resources, with the YMCAs and other civic organizations to really facilitate opportunities. And then our centers also offer flexible funding, which are resources that we can make available to families to purchase certain allowable kinds of services and supports. It could be to hire a respite worker. It could be to buy a membership at the YMCA for exercise and well-being. It could be to attend an adult education class. It could be for adaptive equipment. And I'll go through the list a little bit more further on in the presentation. On the next slide, we also have autism support centers across the state. These are more regionally based and are very similar in terms of the work that the family support centers do, but there's a really specific focus on the unique needs of families experiencing autism. And so really providing targeted information and support and helping people navigate from the point of maybe an initial diagnosis, as well as through different life stages, through adolescence and into transition. And so this services and supports are more targeted and focused in that arena. And people can also choose and use both their family and autism support centers based on their preference and where they live. Likewise, they can help families with applying for eligibility to DDS services. And likewise, offer other, social recreational activities, different groups, as I mentioned, to really promote friendships, peer relationships, peer mentoring, advocacy, and things of that nature. And we also offer a number of more specialized programs and services that are on the next slide. Some start for children at a younger age, but many go through transition or into young adulthood. So I'll just reference these quickly, and likewise, I can make these slides available. But we have a more intensive but short-term program called our Intensive Flexible Family Supports that can be helpful for families who might be going through some kind of period of instability or unique challenges. We see this a lot with, families when their child's going through adolescence and a lot of things change, or if there's issues with their school, or, personally, there's things going on in the family that are just making it more stressful. We use this service a lot with a lot of the families who come from different, or immigrants, or come from different cultural linguistic communities for whom English might not be their first language and need help kind of navigating the system. I also didn't mention with our family support centers, we have a number of designated centers that work with specific populations in areas, the Haitian community, Latino community, Cambodian community. All of our centers are expected to have that capacity to work with a very diverse group of families, but we also have some programs that work specifically, with Chinese, Vietnamese families and other groups where the staff are all bilingual and bicultural. We have a medically complex program, and this is where there's a lot of overlap with some of what Elaine was presenting from DPH. And this is really for children living with their families up through young adulthood, age 25, who have very complex medical needs, are also often receiving continuous nursing services at home. And this really provides some wraparound case management, coordination, and other wraparound services to help the family. These services just require a referral from the service coordinator at the area office. So yeah, I'll come back to the question in a minute. And then we have a children's autism waiver program for children age 3 up to age 9, but it's a 3-year program and really provides comprehensive ABA and in-home supports. And then another program we offer for children through transition age is a partnership with the Department of Elementary and Secondary Education, and is really a way to provide supplemental and complementary in-home services that will help that student be more successful both at home and at school, and really prevent, the need for an out-of-home or residential school placement. So there's certain criteria that need to be made. That program is really expanded over the past few years with some increase in funding, but it provides, I think, a nice set of resources that can be helpful to families who need that kind of continuity of services, often some ABA or behavioral services in the home, so that there's more continuity with the school program. And the next slide gets into a little bit more about our flexible funding. So I want to be clear that, the resources that are typically made available to families, there's some funding caps and limits. We're usually talking somewhere between like $500 to $1,500 a year that may be available to families, sort of based on needs and, often our budget appropriations at different times. But we've really tried to make a commitment to offer resources to as many families as we can and to make that a more continuous resource. And again, it's really to be flexible in trying to address what might be some of those needs families have that aren't covered by insurance or school or any other resources. So, respite is a good example that often, there isn't another resource for that, but it's really so important to families to be able to have that break. We can often help with purchasing adaptive equipment, helping fund different recreational opportunities, paying for swim classes, things of that nature. And we can also help with short-term emergencies. And I will say that during COVID, we were able to even create a little bit more flexibility. And we were really able to, I think, provide some really important kind of lifeline resources to families during that time, helping people with food insecurity and getting access to, iPads and Chromebooks so people could engage in virtual services. So these are flexible funding is administered by our family support centers and programs. It can be administered in a few different ways, and we try to honor family choice in terms of what might be most helpful. The next slide goes through a little bit more detail about some of the flexible funding kinds of expenditures. So we also help a lot with specialized clothing and nutrition, buying air filters, for families. I mentioned some of the personal growth, enrichment kinds of things like Y memberships, adult education classes. We can provide some funding to help with educational advocacy and support, and also provide some assistance with vehicle and home modifications. So there's a lot of flexibility in here, and the staff person at our family support programs works with the individual and our area office to process the requests and to make the approvals. The funding always has to be authorized by our area offices, but it's all administered through our family support programs. On the next slide, there's also a few other services that we offer to people living with their families, and that might be beneficial to families as well. There's a range of what we call our in-home or community support services. Again, that can be a respite service. It can be a companion service. So if someone wants to do something in the community but needs someone to go with them, whether it's to the Y or to a club or group or some other activity in the community, they can use this companion service. The individualized home supports really focuses a lot on more skill development, independent living skills, cooking, shopping, budgeting, money management, helping people, be more self-sufficient, independent in the home, peer support, as well as behavioral support and consultation. So funding has to be allocated from our area offices, but there's qualified providers. So what's different about this than the flexible funding is that agencies are qualified and they identify the staff who provide these services. And then another service we offer to all families is our family leadership series. And there's a number of family leadership development opportunities that we offer that really can help people both develop sort of a good vision, get the information, resources they need, connect with other families, but also, if they're interested, play a role in kind of advocacy and helping kind of shape policy and future directions and identifying areas for need in future development. And then on the next slide, similar to what Elaine talked about at DPH, we've also, and we're working closely with DPH on this, have really started to kind of embrace this charting the life course framework as a way to really support good person-centered and family-centered thinking and practices. So a lot of what, the work through our family support centers and through our service coordinators is really helping individuals think about kind of this vision for a good life, what it is that they really want, what they don't want, which sometimes we're all a little bit more clear about. And then what are the things that are going to help us move towards those better outcomes, and what are things we really want to try to avoid. So really thinking about this as a trajectory. How do we sort of develop that sort of plan, goals, vision? And this is particularly relevant in the transition planning phase, and something we're really introducing with our service coordinators. And on the next slide as well, and you'll see this along the bottom here, it's really starting to look at all of these life domains across all the life stages. And again, so in thinking about transition planning, and as Elaine was mentioning, there's a lot of great resources and tools that offer a lot of great exploratory kinds of questions and probes, and also help build a portfolio, both from the person's point of view and the families, thinking about what's important on what I want to do on a day-to-day basis. What are my community living goals? What's important to me about my social relationships and friendships, and how do I want to be connected to faith communities and healthy living she was referencing, as well as issues related to guardianship and supported decision making and advocacy, and kind of playing an active role in the community. So these are areas that we sort of integrate in our family support services. And so I think that just brings us to our last slide that also lists some resources. One thing I'll mention is our, we contract with the Rewarding Work Respite Directory, which identifies staff who are interested and willing to provide respite or other in-home supports. It's free to people who are connected to DDS, or anyone can use this access code. So if someone's looking for a respite worker or someone to provide some in-home supports, that's available. Our directory that includes all of our family support, autism support centers is on our website. It's going to be updated later this week, but it can be found there on our website, as well as more information on our family support services and the same link to the Charting the Life course. So I'm going to stop there, Deanna. I think my contact information, and I know there's a few questions in the chat if we have a few minutes.
So I can read the questions. One of the first question is, does DDS sometimes help families navigate applying for guardianship?
Yes, I'd have to say, so often our family support program centers offer lots of trainings on guardianship, but yes, there are staff. I mean, they can't do all of the required documentation, but they can help walk people through that process. And so I think that's a very good place to go for some information and resources. And often there's some training and connections people can make around the guardianship process.
Great, wonderful. And second question is, are there plans for any funds to be used for those 22 to 28-year-olds who have autism but do not qualify for DDS, graduate before 22? Specifically for social groups and life building skills, or for recreation? Most transitions happen between those ages.
So there's two. So they don't qualify for DDS because they graduated. So one of the options is whether people want to apply now. You don't have to apply by age 22. I mean, it doesn't close the door if you have not applied for eligibility. People apply for adult eligibility into their 50s. you know, at times. So, I mean, it's obviously best if someone's making that transition. So if someone is not eligible now and you think would meet particularly our expanded eligibility, I encourage them to apply. And we have expanded some services and resources through our Autism Support Center, specifically focused on adults with autism. And people could access those services, and they're focused a lot on sort of these kind of social groups, peer groups, community networking, and those connections. Those resource centers are listed in the directory. Again, there would be one in each region that people could connect to.
I have one quick question. And so I was wondering, in terms of which family support center or autism resource center a person chooses to use, are they limited by the area that they live, or if they're willing, for example, to drive farther, so then that way they can access the resource center that's specific for Cambodia, more tailored to Cambodian patients? Can they do that, or do they have to stay to the one closer to them?
So it's a great question, and an area probably where it'd be great if we could have more flexibility. So there's some services that people could access at any center. Some of what I was describing, like some of the trainings, you know, some of the groups that meet, even just calling for information and referral. But when you start to talk more about some of the funding services, then that does need to come through the area office that the person is connected to. Sometimes they can work out relationships. Like I know one of our centers that works with Chinese and Vietnamese families, two of our area offices partner together and, you know, fund some of those services. So, you know, I think it's worth raising, you know, both with the service coordinator to see what the options are, but there are services you can access at any center or any autism center. But then when it comes to things that require funding to participate in, that there needs to be a link back to the area office that provides the funding. So I know it's a little bureaucratic, but part of how
where we're at right now. Well, that was great.
So,
thank you so much. I definitely learned a lot myself.
Well, good, thank you. And I did see if someone can email or text someone, or is that a different question? Oh, that's telehealth. Okay. So I was going to say people can reach out in different ways, and we have found during COVID that there's been some better communication, particularly with some of our adults with autism, using technology instead of always having to talk with people on the phone. And so I think it's really expanded ways for people to connect and build relationships, and something I hope will carry forward.
Yeah, great. Thank you so much.
Thank you,
It was
everyone.
wonderful. Thank you. And so for our next presenter is Jay Geyer, who is a clinical social worker at the CCSN, Center for Children with Special Needs, and he will be speaking about guardianship. Take it away, Jay. Thanks.
Thanks, Deanna. I'm going to try and share my screen here. We'll see how this works. All right, can everybody see that okay? Great. All right. So I'm going to be talking about guardianship, and when we refer to guardianship, we're really talking about the process of figuring out what a youth with special health care needs is going to need, and what kinds of help and how much help are they going to need to be able to safely and successfully negotiate a shift into adulthood. And being more independent. Okay, let's see here. I need to figure out how to get my slide. There we go. So, so I'm going to be talking about the guardianship process and different levels of assistance that youth can obtain and how a parent goes through that. So healthcare providers can help families and young people get ready for this by being clear with them about what the nature of the child's challenges and strengths are, and helping them to understand what the implications of those things are for adulthood. And part of that process is figuring out how much help a child might need and or protection a young adult will need. And then discussing with them resources, supports, recommending legal help if that's what's needed. As we know, when you turn 18, you are legally emancipated. You are legally able to make decisions for yourself, negotiate contracts. If you're still in the school system, you sign your own IEPs and things like that. So there's a big, this is kind of a magic line in our society, and one that families need to be prepared for if they have a youth with special health care needs. So I'm now going to talk about different kinds of guardianship options. So oftentimes when we hear the term guardianship, we're thinking about kind of an on or off switch, you know, that someone either their parents or their guardian, or they are independent. And there's actually many different options in between those two extremes. So this slide shows options ranging from the less restrictive to the more restrictive. So at the less restrictive end of the continuum, you have supported self-advocacy. So not all people with disabilities need guardianship or need the court to be involved. There are a lot of resources available for self-advocacy and self-determination. And there are a number of alternatives that don't involve the court system. And as we go ahead, I'll talk about some of them. Then working our way up in terms of more restrictive options, we get to limited conservatorship and full conservatorship. Conservatorship has to do with the management of someone's finances and their property. And again, it's not an on-off switch. There can be various degrees of conservatorship that someone needs. And then moving beyond conservatorship is guardianship, and there's limited guardianship, which specifies the areas of life that a guardian is where the guardian will make decisions for the young person and the family. And in full guardianship, the guardian has full authority to make all decisions in all areas of their life. So looking down again at the less restrictive end of the continuum there, one option is to make a supported decision-making agreement. And to find out more about this, I would refer people to this website. Oh, maybe this is embedded. I wasn't sure if I could embed these. Okay, we won't do that right now. But at any rate, hopefully we're going to make the slides available to everybody, and then you'll have some of these websites and so forth you can go to. But this website brings you to a 36-page guide for families and their youth that takes you step by step through thinking through how much support will I need, who do I need it from, when is it needed, and making a support agreement with a team of people who are going to be that person's supports. A family can legally appoint an advocate who can help a disabled individual with a variety of things. Another option is the durable power of attorney. This is less restrictive than guardianship or conservatorship. It allows the youth with special health care needs to keep control of certain aspects of their care and their finances where that's appropriate. It's usually free or inexpensive, quick to set up, and the court does not have to be involved. And there's a website there, a link to find out more about that. The healthcare proxy, I think most everybody is familiar with this, and this allows the family to help manage a disabled person's health care. Now, healthcare proxies we usually think about them as coming into play in medical emergencies, but they can be used in routine medical care. A number of physicians will acknowledge them in routine medical care and can be the basis for the authorized representative for the youth with special health care needs in dealing with their health insurance company. Some of the additional ways that families can help with self-advocacy without getting the court involved is the familiar release of information so that parents can talk with healthcare providers, establishing a joint bank account, which gives parents access, setting up a special needs trust where an appointed trustee is responsible to make sure funds are used for the disabled person's needs, and representative payee. This is where whereby a person in the family or a trusted person is identified to receive their Social Security disability payments and manage them. As I said, conservatorship applies to finances and property. So again, we're moving up in terms of restrictive, the kinds of guardianship options. There's limited conservatorship, as I mentioned, and full conservatorship. And that's apart from guardianship. Moving up further, there is the option of limited guardianship. And these are, I don't know how well you can read this slide, but these are some examples of the kind of agreement that can be made for someone with special healthcare needs in terms of leaving areas that they have a right to be responsible for in their life, or carving out areas that someone else will help them with. Okay, the guardian, as appointed by the court, and we'll talk about that process in just a minute, is responsible for ensuring that the disabled person receives the needed care and services that they require. They're responsible for consent for medical care and decisions, signing legal documents, keeping all legal, medical, and financial records. And they have to send annual reports to the court on their on being the guardian for the person for that year. So a big part of this, I think the most challenging part is not so much what the options are and getting through the red tape of setting them up, but it's figuring out what this the youth with special health care needs from people, and finding that fine balance between the independence that they need to have a fulfilling life and develop as a full person, or continue to develop as a full person, versus where they really need people to help them, either to be safe or so that they're not taken advantage of, and so they can navigate things. So this often requires a team, and it requires some research and work that might involve not only the family, but they might want to consult a lawyer, working with developmental specialists, psychologist, or therapist who knows their young person, teachers, a DDS case manager, looking at recent evaluations that have been done. And if they don't have recent evaluations, they may need to have updated evaluations of their cognitive and adaptive functioning to sort some of this out. So the goal is to provide enough structure and support for the person with a developmental disability to be able to live as independently and healthy, independently as possible, have a healthy and productive life, given whatever their strengths and challenges are. And each person is, as we know, is very different and requires assessment. I'm not going to spend a lot of time on these next few slides, but just to review, these are some of the parts of domains of a person's life to take into consideration when thinking about what they need in terms of oversight or guardianship. So safety skills, whether or not they understand the need for security in the home, whether they can manage a kitchen safely and understand kitchen safety, whether or not they can use public transportation or drive a car, whether or not they have to have someone going with them everywhere they go. What are their communication skills like? Are they able to communicate and self-advocate effectively? Do they understand when other people are, saying things to them? And we can all think of, as providers, of young people that we've worked with where they maybe got in over their heads in a situation, maybe the police got involved because people didn't understand what they were trying to do. I'm thinking of a young man with autism who I worked with a number of years ago, who was fascinated by horses, and he would stop by a horse farm and watch people riding the horses, but he didn't realize how this might come across to other people. His just standing there and staring at young women riding horses all day. And so the police were called, and there was a lot of unnecessary problems there. But so it was an example of somebody who couldn't really explain what he was doing there or why he was doing that effectively. Living arrangements. So you have to be able to make decisions about where you're going to live and figure out the ins and outs of that, and also to be able to live with some other people in a harmonious way. Managing daily living skills, or ADLs as they're often called, and understanding how well the person is able to manage those. How well can the person understand medical care, understand when they need medical care, be a part of decision-making about medical procedures. To what extent can they understand their own educational needs and figure out how to plan for and pursue those opportunities. Understanding money and understanding property and how to budget funds and things like that. Understanding how to go about finding a job and finding a job that matches your abilities. And lastly, legal and decision-making, being able to understand documents, legal contracts, and so forth. These are all things that need to be thought through. So for a youth who has had a developmental disability of some sort all of their lives, whether it's intellectual or maybe not intellectual, but developmental disability that nonetheless interferes with their ability to manage some of those domains I was just talking about to a large extent. What they are going to need, and now we're talking about how to establish the need for guardianship. They're going to need a clinical team report, which is put together by a physician, a psychologist, and a social worker. People who have what I would call an acquired disability, say they've had a brain injury or something, or they've developed an illness that's interfering with their functioning, they need what's known as a medical certificate. So I'm going to talk a little more about a clinical team report. This is a probate and family court document, and it provides information for the court to go on to decide whether or not the person is disabled. And it includes description of the severity of their disability, how it impacts on their decision-making ability, and their safety in the community. So to file for guardianship, a family will need to, first of all, figure out whether all those things we talked about, and then to have pulled together a team of a social worker, a psychologist, and a medical doctor if, in fact, their youth has a significant disability that's going to require someone to be their guardian. They need to file a petition with the court to become their child's guardian. A hearing is scheduled. They have to submit a care plan to the court 60 days after the hearing, and then they renew that care plan yearly. And there are a variety of resources for going through this transition. The Mass Rehab Commission, the Department of Developmental Services, as we just heard about from our last speaker, ARC of Massachusetts, and their local support centers, the school team, AANE, the Asperger's Autism Asperger's of New England is another support service agency to know about. There are a variety of links here, and a number of my slides drew on information from the Exceptional Lives website, which has some just great information about guardianship and seeking it out. Here are a number of resources that have to do with self-advocacy. Let's see if I'm leaving anything out here. This slide just reviews our own procedures at the CCSN for going through the developing a clinical team report. Right now, the CCSN social workers serve families and youth who are either established Tufts Medical Center patients or are patients of NEQA physicians. So, and that's about supplemental security income. It's just kind of an extra slide. But maybe I should pause at this point and see if we have questions. Let's see.
So Jay, I have a quick question. So if you are not, let's just say you are community-based pediatric practice, and you're not necessarily associated with any academic center, how would you recommend these practices advise their patients on how to find a place to get a clinical team report?
Right. So you're talking about somebody who's not part of NEQA and they're not part of the academic center, right? So, so for one thing, they could work with the Department of Developmental Services, who provides support for guardianship. So assuming that the youth has either autism or an intellectual disability. Also, if they've worked with a therapist or a psychologist, usually if they've had, if they have special healthcare needs that impact their psychological functioning or cognitive functioning, they will have had assessments along the way, and that person may be able to be part of the team report. The testing itself doesn't necessarily have to be recent, but there has to be a body of testing that is, shows reliably kind of that the person has impairments. And then the psychologist needs to interview them recently, but doesn't necessarily have to do testing right now, as part of it.
Oh, I see. So there just needs to be sort of a consistent picture that's been built over time.
Right. They need a consistent picture. They could contact a social worker, or oftentimes, their primary care doctor could be the MD on the team report, and oftentimes, a MD or a psychologist will have a connection with a social worker, or they could contact the Massachusetts NASW chapter, National Association of Social Workers, the state chapter, to find a social worker. Yeah.
Okay, I see. Thank you. We do, so I can read this question out loud, if that's okay. This question is from Carla. Do you find parents more or less reluctant to seek guardianships? And are there circumstances where someone other than the parent is preferred?
I think, yes, I think it's, so the first question is kind of the tougher issue. And I think that, all through my own experiences working with families, that throughout a youth's development, parents kind of have to come to terms with their child's limitations, as well as strengths, and that sort of gets reworked as they hit different stages of development. And I think, becoming an adult is definitely one that, where sort of the rubber meets the road, so to speak, in terms of thinking about how independently can their child function in the world. Do they need to take steps to protect their child, either, from being taken advantage of, or from squandering, their money or whatever. And that I think that is really hard for many parents to work through. And so I think this process is something that needs, it's not something that is can be necessarily done quickly. The psychological part, the harder part, needs to be worked on in an ongoing way. But sometimes a therapist or, can be helpful, or a developmental specialist or an MD, the PCP can be, helpful with that. And then let's see, the last piece of that question, you don't have to, the guardian does not have to be a parent. The guardian could be appointed or chosen by the family, but they have to agree, obviously, to take on that role.
Okay, and another question we have is in terms of this building this consistent picture of their profile, does school testing count?
Does school testing count?
Yes. So for example, the psychological testing from school evaluations.
Yes, very much so. I think that that helps build a picture. And if the school psychologist, if they're a licensed psychologist and willing to take on that role, they could be the psychologist on the clinical team report. As far as I understand it to be the case, we have had school psychologists who, who opted to be in that role, although more often I find that they're restricted, they're usually told by the school that they don't want them to extend themselves in that way, but.
Oh, I see. So usually it's they would need to get permission from their higher ups.
Right.
Okay.
Right. But say when one of our neuropsychologists at the CCSN has done a report, they usually review all the past testing that was done to see, again, has that picture been consistent, over time?
Mm-hmm. Great. Wonderful. Any last minute questions? I can also, if any questions come up, after the symposium ever, please go ahead and email me and we'll forward it to the appropriate speaker. Okay. Looks like that's it. Well, thank you guys. Thank you to all our wonderful speakers tonight. If I will, again, if you have pre-registered with me, I will go ahead and send around the PowerPoint or a PDF of the PowerPoints with the resources. And if you have not registered with me yet, just go ahead and shoot me an email. I'll go ahead and type my email in right now in the chat window. It's dlau, DLAU 3 at tuftsmedicalcenter.org. And thank you. Thanks everyone for coming. I hope everyone has a wonderful evening. Take care. Bye.